The Arts and Health Coordinator Programme has been very successful at a very relatively low cost intervention in stimulating and supporting the role of the arts in achieving positive health outcomes. And the outcomes have contributed to positive impacts both on physical and mental health and well-being of patients, of staff, especially during the pandemic, and the wider public, across a range of health and related functions. So both prevention, which others have highlighted today, mitigation, treatment, and also key recovery. So one of the key challenges at the moment in Wales and in other areas of the UK is around patients being discharged from hospital and the support that they need, whether it's rehab or others. So the Arts and Health Coordinators have really supported how we can support patients and people to go back home.
We have artistic organisations that significantly and specifically interact with communities of identity and communities of experience and have particular expertise in creating communication, trust. They have relationships of trust and ownership with those different communities and their cultures. And that's a huge opportunity for public health. And many of us, particularly during COVID, maxed out on how could we engage through those expertise and those expert relationships with communities of identity and experience, because we know that top-down messaging just wasn't cutting through. And so actually working with cultural organisations that were rooted in those communities was really key.
What I'm talking about is that we need to deal with the macro. We need to deal with the fact that we have 1 million children living in a state of destitution, and that ought to be an important aim of policy. But we also need to deal with the micro. We need to say, what can we do to help improve the quality of people's lives?
We have a role, but probably as a partner, an influencer, a voice in the room. And we describe that role as being an anchor institution. We have that responsibility to our population, to our community, and we need to use our influence, our skills, and to drive projects and programs that affect that wider health and well-being. And then the top of our kind of steps, and where we particularly have focused our cultural commissioning, is around non-medical interventions, but directly for a medical need. So that's where we're taking a clinical need and we're adding a non-clinical intervention to improve the outcomes for that individual. We've seen a significant improvement in anxiety with being reduced and post-contact health utilisation. And of particular note, ED admissions, caveating it's a small group, but for pre and post reduced by 80%. So that's a really huge improvement. The commissioning framework we've built around working with the VCSE, that has also been essential. But I think that the key has been about building that confidence in a sustained way over time, influencing through both the data set, yes, but also the testimonies, the stories, and thinking about where we feed that in. And then building that confidence around their place in the clinical intervention and the health benefits that we can demonstrate.